Welcome you to the lecture on immunodeficiencies. We are starting with antiphospholipid syndrome or antiphospholipid antibody syndrome, commonly abbreviated as APLA. Here we have antibodies against beta-2 glycoprotein known as anti-beta-2 glycoprotein. The beta-2 glycoprotein is present on the plasma membrane. The beta-2 glycoprotein, when it forms a complex with other negative anion, the beta-2 glycoprotein has the tendency to bind or attract the negative anion like phosphatidylserine or phosphatidylinositol. That against that complex we develop antibodies. That is the anti-beta-2 glycoprotein. So the first and the most common antibody seen in APLA is anti-beta-2 glycoprotein. The second antibody which is seen is the anti-cardiolipin. Anti-cardiolipin antibodies are those that recognize beta-2 glycoprotein when it is bound to cardiolipin. Cardiolipin is normally restricted to the inner mitochondrial membrane. Anti-cardiolipin is basically a misnomer. They usually reflect the reactivity to beta-2 glycoprotein phospholipid complexes and not cardiolipin alone. Why or when does the cardiolipin becomes more relevant? Under conditions of cell necrosis or apoptosis, the cardiolipin which is present on the inner mitochondrial membrane is exposed to the cell surface. In such cases, beta-2 glycoprotein can bind with the cardiolipin and the antibody is anti-cardiolipin which can recognize it. So in general, the beta-2 glycoprotein is the main culprit. That is the take-home message. What do you understand by lupus anticoagulant? These antibodies were initially found in when the disease was first discovered. It was seen in a systemic SLE patient. So therefore the name lupus anticoagulant, but it has nothing to do with SLE. What is the pathologic significance between the anti-beta-2 glycoprotein and the anti-cardiolipin? Since beta-2 glycoprotein associates with the endothelial cells and the platelets, the antibodies against it promote a prothrombotic state. This is the central mechanism of APLA, explaining the increased risk of arterial and venous thrombosis. There is a laboratory paradox in APLA. It will present with thrombosis inside the body, but in vitro there is an elevated APTT. Elevated APTT signifies increased bleeding. So even though there is thrombosis inside the body, why should the lab test have a prolonged APTT depicting an increased bleeding within the body? This is because the antibodies target the phospholipid binding protein. That is the beta-2 glycoprotein. In the clotting assays, they bind to phospholipids in the reagent and block the phospholipid dependent steps for the prolonged clotting to happen. So the clotting does not happen in vitro, therefore the APTT is prolonged. But in the body, they promote platelet activation, endothelial activation and complement activation which favors clotting. There is a strong association with recurrent pregnancy loss due to placental thrombosis and infarction. It can also cause false positive syphilis screening, that is the false positive VDRL or RPR test in SLE patients. Why? This is because in VDRL or RPR and the cardiolipin agent antigen is used in the diagnostic testing of VDRL and RPR. In APLA patients, there is anti-cardiolipin antibody. So, when the cardiolipin antigen is used in VDRL, the anti-cardiolipin antibody which is present in APLA cross-reacts and produces a positive test. In short, they will not be having syphilis, but yet the VDRL will be positive because of the cardiolipin agent used in VDRL and the anti-cardiolipin antibody present in APLA. Let's see one clinical case in hypersensitivity. 35-year-old female with SLE presents with diffuse proliferative glomerulonephritis. What is the most likely immunological mechanism? In SLE, there is an autoantibody production against nuclear antigens. We do have immune complex formation. Anti-DNA antibodies bind to DNA forming complexes. These complexes, known as immune complex, deposit in the glomerular basement membrane, resulting in diffuse proliferative glomerulonephritis in SLE. Let's have a look on chronic granulomatous disease. In chronic granulomatous disease, there is a NAD oxidase deficiency. What does this do? The oxygen is converted into a superoxide, that is O2 negative, by the NADPH oxidase. The O2, that is a superoxide, can get converted to H2O2 by superoxide dismutase. So O2 to get converted to O2 negative is by the NADPH oxidase. Chronic granulomatous disease is X-linked recessive, primarily affecting the females with the deficiency of NADPH oxidase. So the oxygen is not converted into the superoxide molecule. If it is not getting converted to superoxide, then the further steps, that is for it to get converted to H2O2, is also not possible. That is done by superoxide dismutase. The H2O2 will get converted to HOCl, hypochlorous acid, with the presence of myeloperoxidase. Even that also doesn't happen. So they are more prone for infections, right? Because this is what happens in the inside the cell. The respiratory burst happens because of these reactive oxygen species, and therefore the microbes are killed. But due to the deficiency of these enzymes, the superoxide is not produced, and therefore the microbes are not killed. I have a good news for you. The thing is, the certain microorganisms, all the catalase negative organisms, they don't produce catalase, as the name says. All the microbes, all the pathogens, they will be producing H2O2 as a result of their respiration. Our cells can make use of this H2O2, which could not be produced because of NADPH oxidase, can make use of this H2O2, and if there is myeloperoxidase, that H2O2 can get converted to HOCl. There is only one problem with that. In case they have in catalase positive organisms, they can convert that H2O2 to H2O and oxygen, so that we will be left out with little or no H2O2 to get converted to hypochlorous acid. Therefore, in catalase positive organisms, NADPH oxidase is very severe. Oxidase deficiency is very severe. Now, what are the catalase positive organisms? The mnemonic is spaceship. S stands for Staphylococcus aureus, Pseudomonas, Aspergillus, Candida, E. coli, Serratia, H. pylori. So they are the catalase negative organisms, and those with chronic granulomatous disease are more susceptible to these infections. You can have a question like 33-year-old female with shortness of breath, fever and sputum showing gram-positive diplococci. Which enzyme initiates intracellular killing? NADPH oxidase. Gram-positive diplococci is likely S. pneumoniae that are particularly dependent on oxidative killing mechanisms. We have phagocytosis happens, and after that the NADPH activation happens, the respiratory burst that produces H2O2 and hypochlorite. So high H2O2 levels overwhelm the bacterial catalase. So when NADPH oxidase is normal, then we have high H2O2 levels, whereby the bacterial catalase cannot degrade those high H2O2 into H2O and oxygen. Therefore, the person can bring out the respiratory burst. But in chronic granulomatous disease, the H2O2 production is much less compared to the catalase activity. Therefore, the organisms will survive in the phagocytes. So, a 6-month-old male with recurrent staph infections and diarrhea, what is the diagnosis? Recurrent staph infections, recurrent staphylococcus from early infancy, it is a catalase positive organism. Diarrhea can be because of the catalase positive organisms. It can lead to Crohn's disease. So there is a clinical testing for it. Dihydrorhodamine test. It is the current gold standard over tetrazolium blue assay. This demonstrates impaired neutrophil oxidative burst activity. Why does patients with chronic granulomatous disease have diarrhea? It is because of the persistent infections with catalase positive organisms. Sometimes this diarrhea can even be mistaken for Crohn's disease. What about myeloperoxidase deficiency? Myeloperoxidase will convert H2O2 into hypochlorite. So decreased hydroxyhalide radical formation. Therefore, there is increased susceptibility to fungal infections and all the other infections too. What happens in Chidiac-Higashi syndrome? Let's see about it. There is an impaired phagolysosomal fusion disorder with disrupted microtubules. The microtubule is like a highway which helps the migration of the lysosomes to the phagocytes. So here there is a disrupted microtubule as well as the phagolysosomal fusion is also getting disordered, thereby preventing effective pathogen clearance. This defect can also lead to partial albinism because of the impaired melanosome function. The melanosome is unable to reach the cell to its appropriate place, and therefore they have fairer skin or they are hypopigmented than the siblings. Because these granules or the vacuoles are present inside the cell and they are not fusion. The fusion doesn't happen. The phagolysosome fusion doesn't happen. Therefore, they are present as giant granules visible in the neutrophils and eosinophils. What happens in severe combined immunodeficiency? It is a very severe primary immunodeficiency which is affecting both T cells and B cells. There are two types in severe combined immunodeficiency. First one is the X-linked, where there is mutation of the as you see here in X-linked, which is the mutation in the common gamma chain. The common gamma chain is that important part of several interleukin receptors like interleukin 2, interleukin 4, interleukin 7, interleukin 9, interleukin 15, 21. All the receptors of these interleukins need this gamma chain. Therefore, consequences there is the T cell development fails. Because interleukin 17 is critical, signaling is crucial for T cell maturation in the thymus. Therefore, the T cell maturation fails. B cells are also absent, but B cells are also not absent, but they are non-functional because they need a T cell help to activate. So in severe combined immunodeficiency, there will be problem of both the T cells as well as B cells. Since T cell deficiency, there is viral infections, fungal infections, bacterial infections, and B cell associated protozoal infections too. This is the first type in severe combined immunodeficiency. The second one is autosomal recessive, where there is ADA deficiency. In ADA deficiency, adenosine deaminase converts the normal adenosine to deoxyadenosine and inosine to deoxyinosine. So the consequences, the deoxy consequences, it is the deoxyadenosine gets converted to DATP, which will inhibit the DNA synthesis. Now, if the DNA synthesis is blocked, then rapidly dividing lymphocytes, especially T cells, cannot proliferate. B cells are also affected because T cell help is absent. This is the core in severe combined immunodeficiency. What is the difference between severe combined immunodeficiency and discharge? Severe combined immunodeficiency, hypogammaglobulinemia is very typical because the interleukin signaling is necessary, is important for B cells. The T cells are also important for B cells, and the ADA deficiency where it inhibits the DNA synthesis. Therefore, the B cells which require the DNA is also impaired. Therefore, the severe hypogammaglobulinemia is present. But in discharge, the immunoglobulins are usually normal. In severe combined immunodeficiency, there is a normal karyotype, and all types of infections are seen because both types of immunity are affected. Absent or minimal lymphoid tissue. In discharge syndrome, it is particularly 22q11 deletion on karyotype, and since the T cell is predominant, T cell deficiency is predominant, it is present with primarily viral or fungal infections. It is also associated with cardiac defects. Let's see about the differences between oral candidiasis versus leukoplakia. Oral candidiasis is due to fungal infection like Candida albicans. Chronic leukoplakia can be because of chronic irritation and tobacco and HPV2. Epstein-Barr virus is associated with hairy leukoplakia. Which of these is scrapable? Oral candidiasis is scrapable, but it does bleed. Leukoplakia is not scrapable and it is firmly adherent. Oral candidiasis has no malignant potential and it is treated with antifungals. But leukoplakia, it does have a cancerous lesion. We do have a question like a 1-month-old male with diffuse white plaques that bleed when scraped plus diaper rash with satellite lesions. What is the mechanism? Mechanism is the child is suffering from chronic mucocutaneous candidiasis and the candida thrives in warm moist areas like the diaper region. The satellite pustules are the spread of the fungal infection, that is the candida, from the main lesion. So when you see diaper rash with the satellites, generally think of candidal infection, especially in infants. Linking to immunity, candida is an opportunistic fungus. So defense against candida relies primarily on T lymphocytes, especially the T helper 17 cells which secrete interleukin 17 and interleukin 22 to recruit the neutrophils to mucosa. Neutrophils also do contribute. So in short, the candidiasis is due to decreased T lymphocyte and the condition is chronic mucocutaneous candidiasis. Thank you for listening all this while. All the best for your exams.